So how can we use PCSK9 inhibitors most effectively in patients with established cardiovascular disease, and in particular, patients with diabetes? Well, first, I think we've shown lots of data here that clinical studies have shown that PCSK9 inhibitors not only lower LDL, but they lower the risk of cardiovascular disease in people with and without diabetes. Importantly, PCSK9 inhibitors do not affect measures of glycemic parameters and do not increase the risk of new onset type 2 diabetes. We also know from the epidemiologic data around diabetes, as well as the results of the outcome study, that those who have the highest absolute risk of cardiovascular events benefit the most from PCSK9 inhibitors because the relative risk reduction is fairly stable across the different subgroups analyzed. So when we're thinking about who are the best patients to treat, it's really easy. It's who are the patients who are most likely to have a cardiovascular event in the next 2 to 3 years. This is my approach as a preventive cardiologist as it relates to patients with diabetes and how I treat their lipids. First, in those with established cardiovascular disease, I always start with a high-intensity statin. But given the importance of urgency of getting patients' LDLs as low as possible, in certain patients who have very high LDL cholesterol and whom I think it's unlikely that they'll get their LDL controlled on just a statin alone, I often consider immediate initiation of statin plus ezetimibe. This is my approach. This is not the guideline approach. Second, if the LDL is above goal even on a high-intensity statin, I do add ezetimibe, and then PCSK9 inhibitor if LDL remains elevated. But it's important to think about in patients who need ezetimibe and then a PCSK9 inhibitors, sometimes we'll see LDL cholesterols well below 10 milligrams per deciliter. Because PCSK9 inhibitors were tested on top of statins and not statins plus ezetimibe, in my opinion, it's reasonable to peel back the ezetimibe as long as the patient's LDL remains less than 55 milligrams per deciliter and keep them on a statin plus PCSK9 inhibitor in the event that you have to uptitrate. Again, as I mentioned, in some patients whose LDL cholesterol on a high-intensity statin is quite high, so my threshold for this is 100 milligrams per deciliter, these patients are unlikely to get to goal on ezetimibe alone. So remember, ezetimibe lowers LDL cholesterol by about 15%. So if somebody is on 80 milligrams of atorvastatin and has an LDL of 120, ezetimibe is not going to get them to the 55 milligram per deciliter goal in the new ESC/EAS guidelines. In these patients, I think it's reasonable, if it's accessible and cost-effective for the patient, to consider starting with a PCSK9 inhibitor instead of ezetimibe. This is actually concordant with the US guidelines that gave us a dotted line from high-intensity statin to PCSK9 were it not for the cost. And then finally, we used to only talk about LDL as it relates to cardiovascular disease, but that's not the only lipid parameter that we can actually treat now and lower cardiovascular disease risk. The recent data from the REDUCE-IT study showed icosapent ethyl in patients with diabetes and cardiovascular disease lowers cardiovascular disease events. So again, get their LDLs controlled, pay attention to their LDL, and then look at their triglycerides. And for patients with triglycerides over 135, icosapent ethyl is another lipid-related therapy that we can use to lower risk.